So as I say, today, day 4 of Insights, we're here to talk about smarter decision making for your population. And as you know, I'm very happy and open about my fanboyism, and I have some amazing people with us today. So we have Jason Pickles, Wes Baker, David Sgorbati, and we've got Abraham George. And we would have had the Victoria Cornelius, but I'm afraid that there's a bigger, more exciting thing for her, most probably flu or COVID, but there is something, so poor old Victoria can't join us today. But we have some amazing speakers who are doing some excellent work around population health management. But the key bit about today is those individual decisions for people. And that's hopefully the exciting stuff that we will go through. So first of all, I'm going to ask the panel to introduce themselves as they go through, and we'll start with Jason. And then we'll move to Wes, then we'll go to Abraham, and then David, and they will have a quick intro about what they're up to and who they are. And then I've got some of the burning questions that I have that hopefully will resonate with you guys too. Of course, with this panel, we would love to have more of your chat, so please share in the chat who you are and a little bit about your role. So if you can share that information for us, throughout the meeting, keep your microphone muted. It's that early morning drinking. Microphone muted during the session. But of course, if you want to say something and you have a chat, I would love you to ask the guys directly. So introduce yourselves in the chat box, ask questions in the chat box, and I'll do my best to read them as we're kind of going through. But of course, if I miss it, feel free to post it again and hassle me. And of course, if you want to tweet about the wonderful things that the guys are going to say, that would be wonderful, and I will share some of these details in the chat too. So with no further ado, I will pass over first of all to Jason for a quick introduction.
Thanks for that, Andy. Jason Pickles, Head of Systems and Solutions Development in NHS England, and I kind of lead on the population and person insight work, have oversight of the Analyst X side of it, the Population Health Management Data and Analytics Centre of Excellence, and also, I guess, kind of more like nascent strategic projects that we're trying to do. So hi, Wes, over to you.
Hi everyone, Wes Baker. I'm Director of Strategic Analytics at Mersey NHS Foundation Trust, and I'm working and leading a program called System P with the University of Liverpool, and it's a population health management program for Cheshire Merseyside, and really pleased to be here.
Hi everybody.
Abraham, yeah.
Hi everybody, Abraham George. I'm a consultant public health at Kent County Council. I'm sort of department lead for data analytics, also for joint strategic needs assessment, research and development, and also education and training. So data very much a key part of the work that I do within our team, and then collaborating very heavily with the NHS on population health analytics, including population health management.
Thank you ever so much, Abraham. And over to you, David.
Good morning, everybody. My name is David. I'm a chief analyst at the Health Economics Unit, where I lead a team of incredible data scientists. I'm a computer scientist myself, been working in the NHS for a long time, but my first exposure to a lot of the techniques that help us make these population and person-driven decisions are techniques that I was exposed to when I was still evil, before I joined NHS, when I was doing a lot of marketing and work in the private sector.
Thank you ever so much, David. I hear that Health Economics Unit is a lovely place to work. Anyway, before I kick off, and for those of you who don't know me, my name's Andy Orlowski. I'm a health economist, but I'm also, and it's been a great privilege to be a senior advisor on population health management now for 7 years at NHS England, where I worked at New Care Models, and I've now been working with ICSs. Some say it's because clearly I haven't done a good enough job that it's taken 7 years to hammer this home, and I hope that, or it's just I've figured it out because I have kids and I need to pay the bills. But today you're going to hear from some excellent examples and going through. So please feel free to ask your questions in the chat. I will do my best to look at it. But first of all, starting at the very start, Jason, with all of those key roles that you're playing at NHSE, where can I start? If for those who have joined us on the panel today and joined us as guests, where can they go to begin and start their understanding about their population so they can start making decisions?
So that's a really good question, Andy. And I think if I was to kind of take a step back, there's an awful lot of dashboards out there trying to do population health and unrelated stuff. There's a lot of perhaps misuse of population health anyway, so people are using it as a brand, and maybe the brand is missing the point sometimes of it's not niche, it covers lots of other things too, and perhaps it's a layer of perspective. And kind of beneath all of that, there's a lot of data, an awful lot of data. There's increasing amounts of it, and actually, you know, we're moving into perhaps a more new world of actually we want to be looking at person event level data, linking it rather than perhaps some of the most staid traditional aggregate returns that are used for performance monitoring. So I think if I was to say anything, I think it's challenging. I would also say that there's probably no one place to start other than, you know, you're trying to do something, you're trying to get your head around something, but perhaps you need to think through what questions you're trying to answer to then think about where can you go to look for those answers, because there could be many places. So that aside, the work that we've been doing, and we've been doing it with yourselves and others, Andy, for probably 3 years now, has been very much in that space of there is lots of person level linked data there that we have, IG allows us to access. So if we can, how do we bring it together into that kind of holistic patient level linked data set? And if that's then true, how do you then start doing nice novel insight analysis on it, indeed dashboarding of it? And we have a population person insight dashboard that is available via Okta, should be open to everyone. We can share the link if you've not got it. It's a starter for 10. It's kind of where we've got to with what we were doing, given the resource we had. And I'm very, very keen, if there's people on this call who kind of like it, want to use it, want more from it, if I could kind of get in touch, because I don't see it as my dashboard. I don't see it as NHS England's dashboard. It's kind of something that's there, a start to prompt some thinking, but actually collectively there's more there. So there is that there as a dashboard. In all of it, it's all built up from person linked data. We've applied segmentation to it, so we use Bridges to Health, or an adaptation of Bridges to Health. Where we've actually got to, I understand anecdotally, is probably the biggest person level linked data set internationally with the type of data that we've got in it. So we've got linked person level data for 62 million people going back for the last 4 years, and in that we can kind of come up with a good estimate of pre-existing health conditions in the population. You know, so Bridges to Health looks, or our adaptation, you've got 8 top level segments, and then beneath that there's 54 sub segments, and for the sub segments you could kind of quasi read those as being conditions, although some aren't conditions. Some are stuff like frailty or smoking, which aren't necessarily conditions, the combinations of or key factors contributing to. PAPI dashboards there, I think there's about 10 to 12 different views in it currently. Some are really quite novel, I think quite interesting, you know, so we're starting to look at prevalence of a condition, utilization for people with that condition and actual cost. And by looking at stuff like that, you'll have conditions like asthma, relatively high prevalence, but actually low utilization, low cost, whereas stuff like cancer is, you know, relatively smaller prevalence, but actually very high utilization and cost. And again, you can probably tell it from the data you've got now, but we're trying to do it across the country with the data we have, and there is that type of insight. We can also start looking at, if you've got one condition, what's your relative risk of having other conditions? Easy example there is hypertension is often leading of many other conditions, but you can actually go into your data set and to a predefined level of geography understand, you know, how many what prevalence of hypertension you've got in your patch, but actually of those hypertensive people, they're also kind of highly likely to also have CKD or CVD or whatever. And again, that type of linked data set hasn't been there before, and we've not been able to do it at kind of person level. And in all of it, we're overlaying common socio-demographics, so you can slice and dice that by age group. You can do it by ethnicity, you can do it by gender, and you can do it by deprivation. We are kind of limited by the data and resource we've got, as opposed to the aspiration, which comes back to the thing I mentioned earlier, that if you go in, like it, have a look, and there's certain stuff you want doing, please just do get in touch and we'll try and make it work for you too. From a forward look perspective, stepping beyond the dashboard, as I've mentioned, we've got that linked data set going back for the last 4 years, probably last 10 years, although we don't have some of the depth in it. That's available for England, probably currently internal to EI, but there are aspirations, IG allowing, that those data will be made available to select few people in ICSs. So again, you can get into that kind of common register. And if you can get into our register, our data is based on the data we've got and the quality of that data. You might have more timely, better quality data locally, but at least we're starting to share those common registers to allow the integration if stuff like the federated data platform comes in time, so we can kind of come up with these shared versions of truth. That's something to look out for. The initial kind of release of that type of sort of pseudonymized data, we're hoping kind of back end of this year, early next year, but some of that's subject to IG and all sorts of stuff. Once we start doing that, we are going to overlay also a shared load of geospatial data. So that's not just ODS codes, it's stuff like, you know, is someone in a care home or not? Do they live in a rural area or not? Have they got internet access? Do they drive a car? All sorts of stuff like that will come in. And then there is tooling and capability, which we call ontology, which is arguably just a big linked data set. So you should be able to both cross-sectionally and longitudinally bring all of that linked data together. Our dashboard is a visualization of some of the depth and detail beneath it, but we are also doing sort of insight work, just to want to look out for. It's not being released yet, but it will be going into academic research about multimorbidity and disease progression. So if you have this condition now, you're likely to get this condition in 5 years and that type of stuff. And again, the academics and the medics we've worked with on that all suggest that that's the first time they're aware of internationally we've had the capacity and capability to do that type of data. So I've talked much longer than I actually like talking to, but awful lot there. And I think the simple ask from me would be, you know, please get in touch. Between us all, there's kind of a great set of collective minds and skills, and together we can kind of probably do more than we would all do separately. And I'll shut up there, Andy.
Thank you ever so much, Jason. And of course, that's clearly the answer for everything, guys. So we'll go now. And it's been lovely talking to you. And sorry, where's Abraham? No, it's Pappy is a wonderful resource, and it's great to see some people in the chat who have used Pappy. Yes, Jason will share the link. Please, Jason, share the link in the chat. And for those of you who would like to learn more, and I say the one wonderful thing about working with Jason Pickles, besides his fabulous surname, and I'm able to say that I'm working with a chap called Pickles, is willingness to collaborate and work together. And I think this is one of the great testimonies to the success of his projects, is him working with people as we kind of go through. So we will share more information on the dashboard, and we're going from there. So Jason, one kind of quick kind of follow-up from that. When you're looking at pulling together this data, is there, you know, when you first go to the dashboard, is there a first hint and tip of something that the guys can look at? What would you be the first go-to page on that dashboard that you think is the best?
So I don't know if I'm sharing my screen, am I, Andy?
Not yet. Well, I can only see you, but oh, yes.
No. Yeah, so this is the landing page, and it's quite bland. It's just a form of words, but there's a load of hyperlinks down the side. And what I'd say is there is something called the system view, which, if it loads quickly, gives you a very not superficial, very summary view of your system. You know, so you can go in, look at England, region, SUP, whatever, and web percentage of your population with chronic or healthy. you can kind of start looking how that looks by your PCN, a nice map of it, and then you can start going into different demographic splits in your population and numbers of people with a condition. I would say, as a summary in, probably not answering any specific questions, but as a summary in to give you a general understanding, that's probably a nice place to start.
Fabulous.
If you then kind of step away, if you then kind of step away from that, it then becomes, where do you want to go with it? So there is a, like I said, a risk view in there. There is a risk and multiple long-term condition view. Both of those I think are quite novel and quite insightful and tell you a story that you probably wouldn't have had before. And if you start drilling by stuff like ethnicity, you do get very different disease profiles. That's not surprising because it's commonly known anyway, but it's actually evident in the data and you can drill to it. And it might actually start you thinking more about actually, where are your real pressure points? Where are the real pockets of population that you might want to focus on, rather than perhaps, oh, I'm just going to do, you know, TNO and MSK. You know, it might well be you kind of want to see hypertensive diabetics with respiratory problems. You know, it will very much differ depending on which part of the country you go into.
Yeah.
Previous roles, I used to work in Aqua in the Northwest, the Advancing Quality Alliance, and it's very evident you've got very different needs in the Northwest to perhaps what you'd have down in the Southeast. Respiratory is a big one in the Northwest, and I think the Southeast, you're looking at much more sort of cardiovascular stuff. A lot of that might actually be driven by deprivation and, you know, those wider societal issues anyway. But I think there's a story there. We've tried putting it in order, and there is also stuff like a Pareto view. So once you've been on this kind of layer of look at everything, drill into something, and choose perhaps a more specific area, you can then kind of go in and do a Pareto to try and understand of everyone what's like the 80% you want to major on, or the 20% you want to major on. It's only a start, Andy, as well.
Yeah, it's, as I say, a fabulous start. So thank you ever so much, Jason. And yes, Jason has shared the link. If you kind of scroll up, you will find it in the chat. And again, we can post it again at the end just to make sure that everyone has access to this. And so what we like to do, and what Jason's alluded to, is some of the amazing data that we have to describe our populations. But Abraham, you know, some of the kind of great work that we can do, and I've always been jealous of Abraham because of his amazing integrated data set they had down in Kent, and he's been doing some amazing simulating and modelling of the population and been able to see what changes will happen, what can we expect or predict to happen. But then he's done some amazing work on evaluating afterwards. So Abraham, no one better to ask than, what is the relationship between simulating and modelling and then the evaluation at the end, that kind of creating the learning health system to evaluate the intervention?
Thanks, Andy. Yeah, well, you know, so yeah, that linked data set, which we call the Kent integrated data set, was, you know, we were one of the early implementers nationally around that. Unfortunately, we had to curtail the program given all kinds of significant changes going on in the commissioning, the linked data set, sort of commissioning of linked data set landscape. But we still use it for a lot of research purposes. So yeah, so I think to answer your question, I think years back, you know, we were already starting to explore the utility benefit of using linked data for segmentation and understanding health inequalities within the population, for which Jason has already sort of articulated quite well. The bit that started to become more clearer, or sort of becoming more real, that I started to realize, was that senior decision makers were not just asking questions around questions around health inequalities or surveillance of trends of health inequalities in the past. They were sort of like asking, well, how are things going to change in future? And more importantly, how if we were to invest more in prevention, how would that have an impact on the population? Very, very complex questions to in reality, because from a public health or a population health perspective, you'd need to apply literally tens, if not hundreds, of different sort of factors or assumptions to actually start to simulate the effect on a population, because given that any population, there's at any given time, there's so many different interventions, activities, socioeconomic factors, the prevalence of multiple long-term conditions that you would have to apply to act simultaneously and in real time to actually see what that effect would be. So, and in public health training, we didn't really have that sort of nuanced training around how to actually answer those kind of complex questions. And I happened to stumble across several management consultancies in the past who are actually using those kind of advanced analytics. And the one particularly that became the tool of choice for us in Kent was called systems dynamic modeling. And so we were working with an outside consultancy called Whole Systems Partnership, which are based up in Yorkshire, where they created a sort of something called a cohort model, or the JSNA cohort model. So if you go into our Kent Public Health Observatory website, or Google Kent Public Health Observatory and JSNA cohort model, you'll find the sort of model, the control panel interface of our cohort model. Just a word of caution that we've not updated it for a while, so we're actually planning to update it and refresh it in the next few months. So when you sort of play around with it like a video game, you might find some of the outputs might be a little bit outdated, but rest assured we are going to be updating it over the next few months. But yeah, so the idea was to actually create something called a systems dynamic model, which the sort of useful analogy we use is bathtubs and water. So if you connect, if you have a water tap that's open a water tap, water flows into the bathtub and then flows out through the drain. Connect that bathtub to a couple of other 100 bathtubs with lots of taps and drains. That's your systems dynamic model. And the water that's flowing is basically the population, the flow of the population moving from one health state to another state. So that's what we've done. We've created something called a cohort model, and then we've applied the necessary sort of interface or overlay of assumptions to actually simulate the effect of different prevention activities, like putting additional investment in smoking cessation to reduce smoking prevalence by X%. So how will that have an impact in terms of reduction in long-term conditions prevalence, stroke or diabetes or heart disease over the next 10, 20 years? And then overlaying that, for example, further prevention on alcohol harm reduction or weight management interventions, et cetera, et cetera. So that's what we did. And we were commissioned by our Kent Health and Wellbeing Board some years back to create that model. And we've now started to use that for some of our needs assessment work. And more recently, in the last 2 years, we've created spin-off models, particularly a spin-off systems dynamic model just on COVID, looking at the impact of COVID in our Kent population. And we've used it quite extensively, really, which has been used by by our commissioners and all that, just understanding how will the effect of COVID cases actually have an impact in terms of health and care service utilization rates, deaths, and so on and so forth. So this is about how we actually understand and understand the effect of different interventions and activities in the system. Obviously, there is also the other question, which is, well, has it actually had an effect? And that's where the whole agenda around evaluation comes in. So, and it's become very, very timely because, particularly in Kent, we've rolled out the population health management sort of program over the last couple of years. And we've had some early implementer PCN sites that are already starting to implement their sort of PHM interventions. But so they've been using dashboards like what Jason was mentioning, and they've got a pretty they've had a really good insight of what their population looks like at the moment. But now they're in that stage where they're rolling out their interventions, and they're starting to ask questions. Well, okay, well, if I implement these interventions, what's the impact going to be like? I mean, how do we measure success? And so outcome measurement and how we actually measure that quantitatively, not just qualitatively, so is becoming more and more important. So what we've done over the last 1 year is develop a sort of a very consistent evaluation framework for our PCNs, just saying, sort of clarifying what would be good, better, or best version of an evaluation. So a good example would be just doing a simple before-after patient survey. A better version of that would be doing a sort of deep dive qualitative kind of study, doing some focus group discussions, say, for example, with patients and providers around how that service has been implemented, how is it, how well is it has impacted. But the best, the holy grail that we're sort of promoting is actually we should be using linked data for what we term matched control evaluation. So basically, using a linked data set to identify your patients who are in the population who've undergone that intervention, and then following them up over time, over the next 1, 2, 3 years, and then seeing whether hospital admissions have reduced or increased. And so, but the important thing about that is that follow-up has to be controlled. That means you need to have a comparator group of a similar cohort of people who have got similar baseline characteristics, and you follow them up on time. And then you statistically measure those impacts, usually in the terms of odds ratios or relative risks, and things like that. So, and it's those kind of statistical or quantitative outputs that then become very useful to actually apply onto your system model, because then you can regularly update your assumptions going forward, and then seeing, and then expanding and then overlaying further assumptions to see how will your population actually change over time as a result of the implementation of those interventions. So it's almost like a yin-yang kind of arrangement between outputs from evaluation, and then applying into simulation modeling to generate model outputs that will then help in capacity planning and demand modeling, and then ultimately decision making for further investment in prevention further upstream. Does that, sorry, Andrew, sorry.
No, no, that's, Abraham, that's absolutely fantastic. And I remember when I was working up in Manchester, we were taught by the FAR Institute this learning health system approach. And I think what you've described there is exactly that, and how you take some of those outputs to then to kind of add to and reinvigorate the model to make it more and more accurate over time. One of the big challenges we have, Abraham, of course, is some of our preventative measures pay out in decades of time, especially when we're looking at wider determinants of health. So do you have any advice for those of us who are trying to build these predictive models where we start to look at prevention? So the wonderful work that we're doing around obesity and exercise, or better environment and stuff. How do you tackle the problem of these kind of lag markers, these outcomes that happen in 20, 30 years? How do you go about that?
So at the moment, so when you design your simulation model, you have to be quite, you need to be quite prescriptive about your boundaries of how you actually design the model. And so this lends to the important philosophy of systems thinking, because it's not just creating a sort of mathematical model. You need to actually engage with your stakeholders around conceptualizing how the model works. So at the moment, we've created a model where we first apply the demographics, and then we overlay the prevalence of chronic conditions, long-term conditions. Then we overlay some of the assumptions around health and care service demand. And then we overlay some of the attributable fractions of effects of preventative interventions. At the moment, our model is only focusing on downstream interventions like stop smoking, stop drinking, weight management. And so it's basically behavior change interventions that we're trying to model to see whether it has an impact on year 1 to 5 to 10. The model itself, actually, the lifespan of the model, if you look at what we've done in Ken, is currently on a 20-year lifespan. So, but the next phase of our work is that we will probably continue with that 20-year lifespan. But what we will start to then overlay is the wider determinants of health. So the broader impact of educational attainment, employment, unemployment versus employment, and then the effect of poor housing. So overlaying those interventions, then we are expecting to see significant changes in terms of improved population health benefit as a result of further investment upstream. But the reason why it's so exciting to see this kind of modeling happen is because some of the what do you call it? The way we've been indoctrinated about public health prevention is we seem to use a very linear lens around saying, okay, if we improve housing, then we will definitely improve population health by X%. Actually, if you start to overlay all of those different assumptions, all of and combine them, it's something called the property of a system model is called emergence. So emergence, feedback, and adaptation, 3 important properties of doing a complex system model. If you start to apply those different properties, you'll see that actually those linear effects are not necessarily straightforward. It actually takes there's a lot of basically a dilution or maybe a reduced effect rather than just a simple X% increase, if that makes sense. So the intention is that actually we need to have a more sophisticated understanding and expectation around how different interventions actually work by actually looking at their combined effect. So that is the plan going forward, that actually we will start to overlay assumptions around wider determinants, overlaying on top of the effect of downstream behavior change kind of interventions.
That's excellent, Abraham. And again, I'm sure all of us could talk about that measurement of those things, but that's a whole nother session. Next year, Rachel, Deb, can we have a session about that? But what you've started to allude to there, Abraham, is about making decisions, and how do we make decisions at, at not just, individual level, but starting to look at system level. And yesterday we had a wonderful talk from Alistair McClellan, editor of the HSJ, Sir David Nicholson, who many of us know, who was our supreme leader for a long time, as well as being a chair now of multiple places. We had Professor Sally Markwell talking about it from Oxford Brookes, but none of them are as good as Wes Baker. And Wes will be talking about how he uses population health management, because you've done some amazing stuff up there with your System P. And so, Wes, decision-making at system level in pop health management, what's your experience? What can you share to help make these big changing decisions?
Andy, you definitely should work in the movie business. I can see you in the trailers. You're coming in. So in our program, when we started off System P, and it's been over a year now running, we started off with not actually coming up and saying, this is what we want to work on. We tried to make sure that we engage the whole of the places, and Cheshire Merseyside has a population of 2.7 million, it's 9 places. So we wanted to ensure that everyone can tell us what were the priority areas in terms of the segments of the population that they wanted to focus on. And we had a reference group set up with across the board from partners from primary care, GPs, public health, acute community services, social care. So everyone was around the table to help us kind of inform. It was a small group of people, but it was a mix from different places, wasn't just specifically on one place. And then we did an assessment with public health colleagues, but they took this at their place level discussions to decide which of the 2 priority areas they want to focus on. And from that, 2 areas were identified. One was complex lives and one was frailty dementia. We then did a hackathon event where we brought the whole system together and we said, okay, these are the 2 segments. What are the key lines of inquiry you want us to go away and answer? So we can develop a pack for each place, but it was something that you designed and you asked for, rather than us sitting there and thinking, this is what you need, and me going through the list and identifying key lines of inquiry. And from those hackathon events, we identified a long list of stuff. Some things we couldn't answer in the data, but the majority of stuff we did. And using our combined intelligence of population health action, our CIPHER program, we have a linked data set for our primary care, secondary care, mental health, community and social care data, all linked to the NHS number. And we're looking to augment further data sets on top of that at the moment. So that's the plan. And we have a team of data scientists with the university, and within a combination of using university and using support from NHS colleagues as well, from the strategy unit, but also from Arden and Gem's CSUs as well. So it's a combination of using that resource to bring it all together. And then we had a follow-up hackathon event where we actually went through the packs that we developed. And what we're now having conversations within individual places to see what does that mean. So something when St. Helens looks at their program, they may already have an idea of what intervention they're going to put in place, but it's centered about actionable insights. System P is all about actionable insights. We're not interested in producing dashboards where people just look at them and say that's great and don't do anything with them. We want the so what question. So if someone comes to us and says we want to do an intervention, we're lacking in intelligence, and this is the intervention we're going to put in place, yes, we'll go off and help you produce that information. But if you're coming to us and saying we just want to know more about this population, that's probably not for us to work on, because we're really interested in that next action, and being open about the fact that you may get it wrong. You know, as long as you're moving in the right direction and being safe to say you put an intervention in place, you're learning through that intervention, and you might look at other systems to find out actually what they're doing, because no, you don't have to recreate the wheel. Someone's done it somewhere else. You just want to lift and shift that model of care, and you might think, how do you adjust that to tailor to your population? And that might be within places, you know, something that for example, Wirral might have done a virtual ward. You might want to copy that one. You don't have to go further away to another ICB. Just looking within the own ICB and seeing what other people have done is a good way. And previously within CCGs, you get CCGs, you do want to talk to other CCGs, but now we're one part of ICB. Hopefully those kind of conversations are now easier to have. I remember going from one place to another, and you mentioned another place within the same healthcare partnership, as it was called. You'd get a bit of a negative reaction. It'd be better for me bringing something from Greater Manchester than it was bringing it from somewhere within the own healthcare partnerships. But now that's eliminated, just really helped going forward with those conversations. And then finally, we're doing work about mining the data around for frailty dementia. At the moment, we're looking at virtual wards, we're looking at anticholinergic burden, and de-prescribing those patients using that linked data set. We've further done analysis on complex households. So we've moved from complex lives on individuals and right down out to complex households, and looking at even at the cost of those individuals to a system. And really thinking about the system, and everyone has a part to play. So when we look at the system, although we cost from health and care costs, we also try to add in the cost of police, DWP, local authority, and then say the values we get for this cohort is probably really low. The outcomes are really poor. How can we ensure that we deliver better outcomes and better measure for this population and improve life expectancy? And what we find as well within this within the cohort is people sometimes rush to an intervention. What we do is start from the starting point, and actually who's commissioning, who's doing what in that place. So we sometimes understand what are the teams that are delivering the services, where they're based. Just a simple asset mapping is really, really important. So we do your asset mapping, understand what's being commissioned, look at your governance arrangements. I guarantee we looked at a few governance arrangements, and it was so complicated. You think, well, no wonder decisions don't get made properly, because you have so many different ways, so you can delay that governance. So an intervention doesn't have to be something specifically on a model. It could be just making decisions, making it a lot more easier, and even just small decision makings like that are really important. So we've got evidence where we've done this. The program is still ongoing. There's a lot of work we still have to do, and conversations still having in place, but the feedback has been really positive to the work we're doing. And then the last thing I would like to say is how we work with places with their BI leads and ensuring that we can transfer the scripts. And that's something that we're working on at the moment, about how we kind of we can pass the scripts across so those BI leads can actually run with it themselves. So that's something that we're working. We don't want to just come in and say da-da and then walk away. We want to make sure that we can transfer that intelligence across, and then the BI leads within those places can then drive the conversation, or may want to slice the data in a different way. So they have the control, but we continue to support them in the training. And given that there's a lot of demand on their services currently, it's just taking a bit of that pressure away from them, but then transferring that knowledge across, and then we can carry on the more system-wide conversations. So in a nutshell, that's what we've been doing in Cheshire Merseyside. We've got till the end of March of this financial year before our programme ends. We are hopeful that we'll get funding into next year and carry on with this great work with part of System P, but it's really transformed some of the outputs that we've developed as part of the system. I just want to identify one last thing just before I go, is the comms and engagement stuff. Getting that across. The term System P didn't help. We had a lot of problems with people thinking it's an IT system. So I get people ringing me up saying, I can't download System P. Where do I go and click on the link to download it to do population health management? Well, actually, it's not an IT system, it's a program. So we did a little video to just break down what is System P, what are we doing, why we've chosen the segments, and start to talk about it in a bit more detail. So we've done that as well. So if you are creating a program, just think about your branding, because even if just calling something a system, or some people are confusing it with system C. They thought, oh, is that system C? And no, it's a system P. It's a program of work. So that's really important. You are developing a population health program. Just think about the branding and think about how it lands. And you may want to do a little video just to send it out, because it really has that impact. 2-minute video about your program really helps. And we've animated our video, and I can share that in the link if people are interested in copying what we've done.
Yeah, I think, yes, please share it in the link. And Abraham, I know you've been sharing stuff as well. That'd be wonderful. Wes, I love the insights into action, and of course every analyst, all of us, the 120 plus on the call, are all about, that's the whole point of doing maths, isn't it, is to get some reaction at the end, some action at the end. But you've touched on something that I think is really valuable here, this idea of the social aspect of the work in getting systems to change and how you've used analytics. So we have a session next Tuesday for those of you who want to join for insights about how we're working with 5 ICSs on using technical and social approaches. But from your experience, Wes, that social bit, and as you said, this managing some of the the ingrained potential conflict, however fun-based it may be around competitiveness or whatever it may be. What's your tip for all of those joining about the social bits, about how to work best with other people, how to engage them rather than just the maths?
So it's really important that when you're sharing your intelligence, always go in with this is the first cut. We haven't, this is the definition we've used. It's fluid, and you can change this. We're not saying that you have to use this approach or this segment the way we've cut it in this way. So let's say frailty dementia segment, the cutoff we used originally was 65. Some people wanted 40. We said that's fine. We can do that for you. It was just a way of starting with the intelligence. And don't make the assumption that work hasn't already happened in certain places. Some places were really advanced. So something what we were doing is we're trying to bring everyone up to the same standard. So that's something we talked about. It's not about, we know that you've done really great work, place A, we know you've done fantastic stuff. We're not trying to duplicate the stuff that you've been doing, but it's important that we have a baseline across the ICS. So everyone is starting from the right base. You'll probably take some of this information and already carry it on, while other places didn't have this intelligence the first time they've looked at it, and for them they were really happy to get that intelligence. So you really have to really meet with each place lead. You really have to do that. It does take time. It probably takes more time than actually analyzing the intelligence, that engagement side of things. And we do a lot of that. We go to a lot of meetings, we share some insights, we try to approach things in a positive way. And we always look at it a way, we're not here to step on anyone's toes, we're not take away from business intelligence teams, because the last thing you want to do is when you land on a place is the BI leads feel that you're doing their job when they should be doing it. And what we say to them is, we're trying to take the pressure away from you, we want to work with you on the outputs, and you shape the outputs with us as well within those places. And at the end, we'll hand over this and you will own this outer item. You can then drive this within your place, and then you can rely on us less when we can move on to another project. So that's really important. One thing we've recently done, 3 weeks ago, we had a session, had another hackathon event, or a session where we brought all the voluntary sector organizations, and we're actually giving them a pot of money, how they can best integrate with their services with health and care with the complex lives cohort. So that's something that we've done, and we had over 80 people from different voluntary sector organizations talking about it. So again, don't forget those other systems from housing, voluntary sector organizations, they all have a part to play. Sometimes we always go to everyone else saying we'll just go to local authority, we'll do the health and social care, and we're all fine. But we brought everyone into that conversation, and we've done that now and said, actually, what would they like to see? How can we work together? How can we bring your data into our data sets? Housing do fantastic pieces of work around the cost of living crisis. They support their tenants in different ways. So how can we engage with them to ensure their outputs? And there's some work in Liverpool around working with, for example, Cobalt and the local authority houses around what they're doing for their tenants and how can they best support. And they've actually given grants out to help improve health and well-being for their tenants. So all that work and bringing them into the conversation. So there's a project at the moment in Liverpool called Resilient Families, and they're around the table. We've got housing around the table in that Resilient Families. So I would say, look, start slow. Don't assume anything, and be careful of going in assuming that you're coming here to save the day. I go in from the view as I don't know. I know as much as you. You probably know more than me. but let's work together. And that's the best approach. And I do that with every sector, even housing. If I approached housing tomorrow, I'd say, you've got a bit of the jigsaw that I don't have. I don't know everything, but together we'll probably be able to solve this.
But as you know, Wes, analysts are famed for the gregarious, outgoing natures. We're warm, we're cuddly. You know, now we've got to become sales reps and marketeers, and I have to hug these system leaders who all make these moronic decisions that we have to then justify with our maths. But these are the exciting things, the future for us as we go forward. Thank you ever so much, Wes. And you know, first of all, and a huge thank you both to Wes and David, who actually dressed up for today. So thank you very much. At least you've bothered to get dressed, putting me, Jason, and Abraham to shame. You know, you're not going to get a drink for free for that. But we've talked about some amazing things today about understanding our population, simulating and modeling and the evaluation of it, and then how we take this to drive decisions at system level. So what skills do we need? What skills are needed to help support this decision making? And I can't think of anyone better to ask than someone who I'm intensely jealous of, not only because he's a great musician and has wonderful hair, but his understanding of R and Python far exceeds mine. So I'm a very bitter, twisted man. But David, how would you go about it? What skills do you think we need going forward, and what examples can you think of for analysts that they should be preparing for?
Thank you so much, Andy. Unfortunately, I do get very happy when I'm introduced as a great musician. It's been wonderful so far to hear so much, so many different examples of excellent work happening. Wes, I think, did an incredible job mentioning the diversity of people that we really need around the table to make those decisions. These are not decisions that anyone in a system can make by themselves. And, you know, the mentions of housing and justice colleagues are absolutely crucial. Now, so saying I'm a computer scientist, I'm an analyst. I consider myself an analyst. I'm proud to say that I'm an analyst. I think it's a wonderful profession, and absolutely our role here is to help, is to support the system and in making the best possible decisions. All these people that we work with all know very much what they're doing. As Wes was saying, they know their areas, they know their people. They've been doing what they do for a long time. But as analysts, we can always get the maths, get the data, and try and understand whether there is more detail we can surface, whether there is more that there's more to understand. Now, Jason earlier mentioned, I think, something about the misuse of PHM as a brand. And I think there is a rant that I go on every now and then where I complain about how much talk there is about PHM, and you know, sometimes the doing is not quite where I would like for it to be. And Abraham then followed on talking about some of the complexity that there is in creating good system dynamics models, and how much study. And for me, that is very, very important. Now, as analysts, we have a role to play, but not all relationships are linear. Some of the maths involved are tricky. Some of the studies that we need to do are not that straightforward. And to play off what other people on the panel have already mentioned, Jason again earlier talked about the probability of developing further long-term conditions over time based on your current profile. Now, in the health economics unit, so the beauty, part of the beauty, apart from working with wonderful people in of a team like the health economics unit, is that we work with many different partners on a huge variety of projects. And recently we've been talking a lot about the work that we've done with the Real Center, for example. And that is a very interesting study about what's going to happen as the population gets older? Now, we know that we expect the number of people over 65 to grow from 12 to 17 million by 2039. And we have a bunch of old models that say, yeah, you know, you start getting a bit sick around 50, and then you get sicker and sicker, and then around 70 die. Of course, those models are older. So the question is, given that we are alive for a longer period, when does our health start deteriorating, and how does the different conditions start piling up, and how does that increase over time until the end? And so top line result is actually, yeah, it's a bit of a funny shape on the curve. So it actually starts probably based on the data that we have. We start accumulating poor health slowly, and then we have a big increase towards the end of our lives. But as we looked at the data, it turns out that making such a big statements for whole population is quite meaningless. And I think by 2022, I hope we'll all understand that there is no such thing as a homogeneous population anywhere in the areas that we look at, really. And really those profiles of how different long-term conditions accumulate and have an impact on people over time is very, very heavily dependent on deprivation, on ethnicity, on a number of factors that all work with each other to create very unique conditions. And just one more example I want to give. I appreciate that we all have a lot to say, so time is running a little bit short. We've also done some work on really trying to understand how policies should work when we think about length of stay, because you know, over time we've seen patterns of length of stay in hospital decreasing, and numbers of readmissions within 30 days increasing. And the number of studies have been saying, well, there's a link. Clearly, we reduce length of stay and people come back to hospital. And once again, it's quite easy to do superficial maths and try and get to those results, but we are good analysts. We are very good analysts, and we're going to go one step further. So the Health Economics Unit did a big study on the real cause and effect relationships of different factors. Once again, as Abram was talking a lot about the importance of the data, of linked data sets with patient level information, and that's what we found the richness. So if we look at the data, yeah, sure, we can see that there is a causal link between having those short lengths of stay and readmission, but the picture is much more complex. There's a number of confounding factors, there's a number of covariates, and there's a number of mediators that actually stand between the length of stay and the readmission. And the moment we can understand how depression, hypertension, living conditions have alter that relationship, the better we can make decisions for each individual and make sure that we keep them in hospital exactly for the right amount of time to maximize the probability that they will not have to come back. And I'm just going to mention one last thing very quickly, because we're very passionate about this. So we do a lot of the doing. So we're there doing the maths, but we're also very keen on sharing. So we've been running a number of sessions with the lovely MDSM, and next year we'll be running again, I think it's 11 sessions, January, February, on population health management, giving you the concepts, but also looking at how you code, looking at how you pick the right algorithm. And if you're interested, I'd be very interested. Just drop me a line, and very happy to talk about it. It's all free.
Thank you ever so much, David. And again, I always love hearing from you, and again, the enthusiasm behind analytics. And I'm glad to know that I don't need to learn causal inference tomorrow to have a contribution. But of course, when it comes to my PhD, I still expect you to help me write that competing risk analysis. I'll just drop that here. Guys, just to say, for those of you watching, I do promise that when we rehearse this, David, Wes, Jason, Abraham took about 5 minutes each, and we thought we'd have like an hour for questions. But it looks like we have about 3 minutes for questions. We have dropped into the chat a Menti, and it would be lovely to hear from you, your thoughts about the questions that I've asked. And I'm sorry if they're not the right questions for you, but feel free to pose additional questions and we can ask them there. So in the Menti, you can kind of answer some of the questions or put your thoughts in place, and we'd love to hear from you. We have someone with the hand up. So Chandan, can you go off mute and ask a question? We've got 2 minutes left, or drop it into the chat. Or not, and we'll go from there. But I just wanted to say, as we're kind of rolling to the end, a huge thank you to Jason, Abraham, Wes, and David. You know, in the nicest way, if Victoria had been here, I think she would hate you guys to have to do her segment in 2 minutes. But thank you ever so much for the information today. I just want to share with everybody. All of the guys are really happy to chat and collaborate. One of the great reasons to have them here is that I know that they're willing to share, they're willing to get involved. So if you've got any thoughts, anything you want to follow up, please pick up with Abraham, Jason, Wes, and David, and to be able to kind of talk about these things. A huge thank you. Just to say that there is some wonderful talks, I'd say tomorrow. Join me tomorrow with Nick Carding, who's the journalist who's leaked, well, not leaked, he's reported on some of these wonderful leaks that have happened across data, including new hospital programs and loads of other exciting stuff. And he'll be talking about the big decisions he's seen in data and analytics as the senior journalist at HSJ. So it's going to be a great little chat from him. And on Tuesday next week, we have the sister talk to this one, which is looking at system decision making at a system level rather than at a population level. So, and again, sharing work we're doing with 5 ICSs, about 6 million people across the country. So a huge thank you. Wonderful, you know, wonderful to hear from all of you. Thank you ever so much, the wonderful people who stayed with us, and we'll speak to you very soon. Thanks again, guys.